Okay, thank you for the introduction. It's nice to spend this evening with you, and I'm very excited for the students to share, to go over some papers. So I would ask who is from the students wants to go first? The people I have on top here is Andres with the dual trial of intracranial pressure monitor. Andres, do you want to share the screen for your presentation?
Yeah, sure thing. I have it pulled up right here. All right. So I can go ahead and introduce myself, and the other two members of the team presenting this paper can also introduce themselves. But my name is Andreas. I'm a MD PhD student at Duke. I am excited to be here and to be presenting on this topic. Really interesting paper. But Mark and Michael, y'all here?
Yeah, I'm right here. Can you hear me?
Yep.
Okay, and before Andreas, before you take it away, this is Dr. Stripler again. So we have about 15 minutes for each paper. The interestingest part is really discussion. You guys put great discussion and limiting points in there. So we have 10 minutes to go through your presentation. I'm gonna be really cutting you off after 10 minutes so we all can have a discussion because we have some polls as well. So don't think, I just wanna pre-warn you, but take it away from here. And audience, you can put things in the chats if you have questions or comments, okay?
Sounds great, thank you.
Sounds good. This is Mark, medical student from Stanford. Happy to be here. Looking forward to this talk.
Cool. All right, awesome. And Michael?
Want me to take it away, Andreas?
I gotcha.
So these are, you can go back to the initial slide. We were looking at a trial for ICP monitoring and traumatic brain injury. Go to the next slide. Just wanted to give you a quick background. You've seen a lot of this, but the indications for ICP monitoring. So the Brain Tumor Foundation does recommend ICP monitoring with to help inform care for TBI. ICP monitoring is particularly indicated for severe TBI. This is just a reminder. If you look at the box to the right on the top, what severe TBI is. The middle, so the GCS scale, roughly around 3 to 8. We can talk about the GCS if need be, if we have time. And they also look at post-traumatic amnesia and duration of loss of consciousness to be within this range. So that's sort of the general indication for severe traumatic brain injury, but plus indications of mass effect on CT. So some of these are examples on the right of just examples of that. So hematomas, contusions, etc. So on the left, the second bullet also, you can imagine there's some cases where a person might have a normal CT, but they're in 3 to 8 for the GCS. So things like unilateral, bilateral motor posturing, low blood pressure for people with age of 40 or plus would also be an indication for ICP monitoring. We can go to the next. So for this study in particular, the goal was to compare the efficacy of ICP monitoring versus imaging and clinical assessment for the management of severe TBI, like we've described for patients. So some of the outcomes that they measured, which we'll talk about, are 6-month mortality, functional status at 3 to 6 months, length of stay ICU. There's several other outcomes that Andreas will talk about. Just to talk a little bit about the inclusion criteria for this study, and this is not the full inclusion criteria, but there's some, if you look at the supplement in the paper, there's an extended version. So these were patients who were, like you look at the left, were 13 plus years of age. Like we mentioned, they had a GCS of 3 to 8. One stipulation here was they could have had a higher GCS, but if they fell within 3 to 8 within 48 hours, they were included in this study. The patient had to be admitted within a certain period after injury, less than 24 hours. They couldn't have foreign objects, and they had to be randomized within 24 hours of injury. For exclusion criteria, the lowest GCS score, 3, and bilateral fixed plus dilated pupils, that was an exclusion, or whether it was deemed that the patient had an unsurvivable injury. Of course, no consent, pregnant patients, prisoners, or if they weren't able to do the study because they didn't, for reasons like no beds and monitors, or they had a pre-existing neurodisability.
Awesome. So I'll take it from there to kind of go a little bit over their methods and how they actually kind of broke apart the patients into two different groups. So the way to think about this is like who, where, and the interventions and the outcomes. So who, it was, they had 324 patients, at least 13 years of age with severe TBI based on those inclusion and exclusion criteria. Where this is actually conducted in multiple centers in Bolivia and Ecuador. And then the intervention that they actually had here, as was mentioned on the previous slide, is on one side they did the gold standard, which is why it's in gold, of intraparenchymal ICP monitoring, where they put a probe inside the parenchyma of the brain to monitor the pressure directly, versus imaging and exam-based monitoring, where they would essentially do clinical exam as well as serial imaging. And the outcomes, among others, one of the major outcomes was a measure of functional and cognitive outcome by essentially a normalized summation of different like common measurements of like morbidity and mortality. And so the results, just to kind of get right into it, this is just a plot of cumulative survival over time. And so what you see here is that they actually have this cut out, and they have this overall group over 225 days after injury. And one thing that you can notice here is, first and foremost, in neither the first 14 days post injury nor over the following several months do you see a significant difference between the two groups, which is important to note because these are two very different approaches to monitoring patients. When it comes to the actual clinical outcomes, so there are a variety of different methods that they use to kind of measure outcome here, and one of the ones that they mentioned significant, like throughout the paper, is this cumulative kind of score that is supposed to measure patients' outcome kind of across the board. It's essentially just a normalized summation of different factors like classical outcome score, as well as performance on a mental status exam and other measurements. And neither this nor cumulative mortality nor classical outcome score were significantly different between the groups. And kind of digging a little bit deeper into the nitty-gritty of the results, if you actually look at comparisons between length of stay and other measurements for these two groups, you see that there is a significant increase or skew towards having longer length of stay in the ICU for brain-specific treatments in the group that had only imaging or clinical examination. Also, there was an increase in the probability for decubitus ulcers actually in the other group, the pressure monitoring group, which is interesting. When it comes to the intensity of treatment, it was significantly higher in that group that had imaging or clinical examination. Makes sense because that seems to be part of the actual intervention itself. And this is just kind of noting exactly what that means. It's just the number of times that these patients had that intervention over time. And then, of course, so there's also increased probability of having like hypertonic saline administered for the imaging or clinical group, as well as increased prevalence of having hyperventilation in that group. Also, it's in that the group with pressure monitoring had a higher amount of like barbiturates being administered. We can discuss that a little bit more, but very interesting kind of differences that kind of all over the place, but some make actually a lot of sense. There was no real difference in the adverse outcomes. And with 2 minutes, 30 seconds left, I'll hand it off.
All right, so we're just gonna go through this very quickly. So for the strengths of this study, so obviously this was a multi-centered, randomized, controlled blinded study. I think one of the other, things about it is that most of the intensivists in the country the two countries where the study took place weren't used to using ICP monitors. So in a way, it kind of eliminates ethical issues that would have arose if this study were to have taken place in the United States. Weaknesses. So it's very hard to generalize the findings of this study to patients in other populations because, even within the same country, there are differences in the way patients are seen, pre-hospital, resuscitations, transportation time, rehabilitation. And, you know, it's hard to really generalize this study to like patients in, say, even here in the United States, where the pre-hospital resuscitation is a lot more developed than in Ecuador or Bolivia. And one of the other weaknesses is that the physicians in this site are not as familiar with intraparenchymal monitoring. And also the elderly were not represented in the study. So the discussion was, in patients with traumatic brain injury, ICP monitoring guided management did not improve outcome versus interventions that are guided by imaging and clinical examinations. Although ICP monitoring is the standard of care, this study didn't really give a definitive answer as to whether ICP monitoring improves outcome. It just says, well, it's not better than the control arm of the study, which just means that more research needs to be done. And, you know, one thing that we can learn from this study is that, you know, ICP monitoring is just a tool. It doesn't really substitute for a good clinical judgment. You know, and more research needs to be done to kind of just prove maybe it's better or maybe leads to much better outcomes. For now, you know, it's essential that it should just be a part of a multimodal approach to managing traumatic brain injury in patients.
Thank you. I think that was a great summary of this paper, very succinct, and thank you for sticking to the time. So there are a couple of things I want to point out, and you hit the major points. I think the pre-hospital care in Ecuador and Bolivia is very different than it is in the United States. If you look at the supplemented data, about a third of the patient arrived by private vehicle or by taxi cab. If you have a car accident or you're in a coma because you fell down from the third floor in the United States, you do not arrive by a taxi cab to the trauma bay. And we all know that hypertension and hypoxia are independent predictors of your outcome. So as you alluded, the pre-hospital care is very different. And maybe we don't see a difference because the secondary injury maybe has progressed because there is no pre-hospital care beyond the point of return. So that was always one big takeaway message for me, that we may be losing that window because it already closed because there was no pre-hospital care. I think this is not an argument against ICP, because if you look at the data, both groups were very aggressively treated with ICP, one just blindly and one with ICP monitor. So I think that this is also an important point. It's not ICP doesn't matter. It maybe doesn't matter if you measure it or not, if you aggressively treat. So I have a poll for you, and I'm just going to put this, I'm going to come back to the question, should we aggressively treat? So I'm launching a poll here, and I want you guys to answer this question. Oh, hold on. This is the wrong poll. Hold on. Let me rescue. This is the ICP study poll. Okay. So there's two questions. Where you study, where you attend school, do you guys measure ICP? I want to know my audience here. Let me launch this poll. And then do you think that ICP matters, treating ICP matters in severe traumatic brain injury patients? And I want to see some data come in. And then while you guys are doing this, you have 15 more seconds. I'm going to keep talking because we want to stay on time. So if you live in America or in the first world where you guys measure ICP, my question for you is, would you treat somebody's blood pressure without measuring it before to see what it is, and then give a medication and see if the blood pressure came down? And that's the same way I feel about ICP in the developed world. If we have the opportunity to measure ICP, we want to know what it is, and we want to know if our treatment worked. If and I'm going to share the poll here with all of you. So if let me share the results. So if you work in a second or third world country where there's resources are not accessible, I think this study really has shown a good algorithm of how you still can achieve very good outcomes in severe TBI. It is a very human intensive algorithm. Intensivist at the site, frequent CT scan, frequent exams, and I think we rely more on the ICP monitor. I think these are the points I wanted to make on this paper. Let's see what our audience says here. Where I treat, so 67% are not treating, measuring ICP right now in severe traumatic brain injury patients. If you can put a little bit in the chat, it would be interesting to hear from you of what you use. Do you follow, for example, the best trip trial protocol, or what do you use to treat these patients? So please put this in the chat. And then number two, the ICP study showed that ICP does not matter when treating severe traumatic brain injury. And this is very, I really want this making a take-home message. ICP matters. If you're in a second or third world, or you do not have the resources available, you still need to treat it. Maybe just can't measure it. But look at how the slide that is up right now, how aggressive people received mannitol, hyperventilation, CSF drainage, and barbiturates. So these people were aggressively treated. Okay, so let's go on to the next study. And I think I'm gonna have Michael McGeer and Richard Porter talk about the Rescue ICP study.
Hello, this is Richard. I'm going to be sharing my screen, and Michael's going to kick us off.
All right, how are you, everybody? So we have the Rescue ICP trial of decompressive craniectomy for traumatic intracranial hypertension. For the next slide. All right, so research questions. So decompressive craniectomy, or DC, is the removal of the skull and underlying dura. A little bit of background here. So there was a study called the DCRA study done in 2011 that demonstrated that there was no benefit from decompressive bifrontal craniectomy. However, the study was limited by restrictive eligibility criteria, and it did suggest that there may be a role for decompression in refractory cases. So, so the Rescue ICP study here kind of asks, what is the role of decompressive craniectomy for patients with a traumatic brain injury and intracranial hypertension refractory to typical medical management? Not kind of, not the initial approach. So you wouldn't have a patient that comes in and do a decompressive craniectomy right off the bat, treating refractory cases after medical management. So next slide. So the methods, a little bit about the design and oversight. So it's an international multi-center parallel group superiority randomized trial with the sample size being 398, 202 undergoing surgery, and a control of 196. Inclusion criteria, ages 10 to 65. The patients had to have TBI with an abnormal CT. They had to have an ICP monitor already in place with ICP of greater than 25 for 1 to 12 hours. And an important thing to note here is that patients with surgery for hematoma evacuation were included in this study, as long as they hadn't had surgery like a decompressive craniectomy already. So this is something to note for the patients that were included here. Exclusion criteria, bilateral fixed dilated pupils, bleeding diathesis, or injury deemed unsurvivable, kind of sort of like the previous study. If you want to take a quick look to the chart over on the right, this just talks about the different tiers of treatment that the patients underwent before they were treated with decompressive craniectomy or given solely medical treatment. So stage 1, things that we already have covered in previous talks. If the pressure stayed higher than 25, of note, this for the tracheostomy, mannitol, saline, hypothermia. That's something else that's interesting to note. I believe that this study was done prior to results of the Eurotherm study, where hypothermia may or may not have suggested that there could be some deleterious effects in these types of patients. So I'm not so sure that hypothermia is used anymore. I think it's more normothermia, but let it be known that it was used in this case. If ICP is still high, then we move to either surgical treatment or medical treatment. So next slide. The outcomes. So the primary outcomes here were assessed with the Glasgow Outcome Scale at 6 months. Secondary outcomes included Glasgow Outcome Scale at 12 to 24 months. Also mortality at 6, 12, and 24 months respectively. Quality of life at 6, 12, and 24 months respectively. GCS at discharge, an assessment of ICP control, ICU time to discharge, and economic evaluation. There's a for your reference slide. Next slide. Cool. All right. And a little bit more about the method. So there was a target sample of 400 with 80% power at a 5% significance level. So they allowed for 15% loss to follow-up. There was the outcomes were analyzed via an ordinal analysis method based on proportional odds model. And they performed a sensitivity analysis. So this is a pretty interesting point to make here. Conventionally, the Glasgow Outcome Scale in the literature is dichotomized with upper severe disability counting as being unfavorable. So if you look to the right at the chart, you can see upper severe disability, it's in a box. Traditionally in the literature, that is declared as unfavorable, but those conducting this trial anticipated a high proportion of poor outcomes. So they included upper severe, which was an outcome score of 4, as a favorable outcome. So that's something to note here as well. So keep that in mind. Things like duration in ICU were measured with Kaplan-Meier estimates, and remaining categorical variables were measured with chi-squared, and continuous variables with Mann-Whitney analysis.
All right, so thank you, Michael. And now moving on to the results. So here's a few of the charts that were included from the paper. Table 1 talked about characteristics of the patients at baseline, for which there were no significant differences among the surgical group and the medical group, with the exception of the history of drug or alcohol abuse. There were 35% of participants in the medical group had a history of drug or alcohol abuse versus 24.8% in the surgical group. And then with regard to treatment and interventions, one of the significant things to note here is that for decompressive craniectomy, 37.2% of the medical group also received it in addition to the surgical group, which may have affected the results, and that's something we'll mention later on. And then with regards to intracranial pressure control, that was one of the outcomes they measured. They found that patients in the surgical group had better ICP control compared to participants in the medical group. So with regards to primary and secondary outcomes, some of the main ones. So for primary outcomes, the GOSE at 6 months, we saw that for the surgical group, there were less percentage of patients experienced death, but there were more patients, even though there were more patients that survived, many of them were in vegetative state, had lower severe disability or upper severe disability. And that trend also applies for the GOSE results at 12 months. Patients, and we also see that there's a greater proportion of patients in the surgical group that ended up with upper severe disability, lower severe disability, and vegetative state than in the medical group. And so that's something we're going to be mentioning in our limitations as well. And we'll get to that in a couple slides. But some other secondary outcomes, as I mentioned on the last slide, ICP control was better in the surgical group. Time to discharge among the survivors was 15 days in the surgical group versus 28.8 in the medical group. And whether they did an intention to treat analysis versus a per protocol analysis, they found no difference in how they statistically analyzed their outcomes. So that's something to note as well. So with regards to the limitations, there's a few that we, that Michael and I found in this paper, and also the ones that they shared. So clinical teams caring for patients were aware of the trial group assignments. So there was some non-blinding involved in the study, and there may have been some difference in care, but the outcome adjudication itself was done by personnel who were blinded. There were a lot of patients in the medical group who got decompressive craniectomy, which I mentioned before is around 37%. So that could have diluted the observed treatment effect. They also did not dichotomize outcomes for bifrontal versus frontotemporal decompressive craniectomy. So it would have been interesting to see if there was a difference in outcomes between those two kinds of decompressive craniectomies. And 10 patients were excluded from analysis because of consent issues, and 7 in the medical group were lost to follow-up. They also found no long-term data on cranial reconstruction, which happens usually 2 to 3 months after decompressive craniectomy. But they mentioned that it's an important aspect of treatment that should be explored further. They also didn't assess the effectiveness of primary decompressive craniectomy, which is done more frequently than secondary. And those are a couple of the sources that mentioned that primary decompressive craniectomy is more frequently done. And as we talked about before, for what's included as part of a favorable outcome, favorable outcome percentages for the surgical group might be artificially inflated because of what they considered a good outcome. So thinking about this last slide here, there were a larger proportion of patients in the surgical group with upper severe disability, which they considered a good outcome, which might have. So if we're just considering the green bars and the blue bars as favorable outcomes here at 12 months, there doesn't really seem to be much of a difference in favorable outcomes, whether you treat surgically or medically. And with regards to discussion, when we were talking about the DECRA trial earlier, craniectomy had worse ratings at USC at 6 months versus standard of care despite similar death rates. And early craniectomy is offered as a stage 2 treatment within 72 hours of injury for moderate intracranial hypertension. But this trial excluded intracranial hematoma patients, but these patients were included in this rescue ICP trial. That's something they wanted to make a note of to differentiate themselves from the DECRA trial. And overall, this trial, they were aiming to assess the effectiveness of DC as a last year treatment, as we talked about before. And it informs the concerns that craniectomy simply increases the number of patients who survive but are in a vegetative state or in severe disability. However, they say the survival advantage was extended to dependent and independent living, which clinicians and families should know when they're making treatment decisions. And they were also not sure if ICP control accounted for a lower mortality specifically. They didn't test this association, but it'd be interesting to see if that association does exist. And these are references, and thank you for your time.
Thank you. This is Dr. Stripler again. So thank you so much for this very good summary. Why don't you go to your limitation slides? I think they had a good points there. So I want to unpack something you said. So I think the most important part is how they defined good outcome. Traditionally in trauma, we would put upper severe disability to a poor outcome when the GOSE gets dichotomized. This has traditionally been done. In this case, they put upper severe disability to good outcome. If you just would look up to upper good recovery, if you have craniectomy or not, there's no difference. But the difference comes in when you look at upper severe disability and put that in the good outcome category. So if you tell patients and say, so let me back off one more thing. So their primary outcome was at 6 months. We neurosurgeon, rarely follow our patients for longer than 6 months. We maybe follow them a year. Rehab physicians follow these patients. That's what they do for years. And if you go to a panel discussion or discuss this topic with rehab physician, they laugh you out of the room if you say to them, well, at 6 months, that's how we know how a patient is going to do. They say patients make significant improvement at 1 year and even out at 2 years. And this is an interesting point here because there is no significant difference at 6 months between surgery and not. But at 12 months, there is a significant difference to a better outcome if you do decompression, with the caveat that you put upper severe disability into the group of good outcome. Okay, so if that was published in the New England Journal of Medicine, which has a rule, you're only allowed to put your primary outcome in the abstract. So if people don't read the whole study, they come away, they read the abstract and they come away with another paper that shows that decompressive craniectomy doesn't work. Keeps people alive, but does not improve outcome. And I want to push back on that because at 12 months, which is the secondary outcome, they saw an improvement in good outcome with the caveat that upper severe disability is considered good outcome. And the presenters of this paper pointed out that you need to discuss with the family what upper severe disability means. So what does upper severe disability mean for a patient? It means you can live independently at home for 8 hours. You probably cannot balance your checkbook, if anybody still has checkbooks. You probably cannot figure out the bus schedule, okay? But you can live independent at home for 8 hours. And I think that is a big part kind of my academical mission as well, is we need to learn how we talk to patients and to patients' families in this case, so they make the right decision. What's the right decision for the patient? Doing the surgery is very easy, but do we still have an understanding of what good recovery means in that case? So we talked about primary, secondary outcomes. Thank you for pointing out hypothermia versus normothermia. I think hypothermia is used as rescue therapy, and normothermia is almost should be standard of care in our severe TBI patients. I like what you put in there, bifrontal versus frontoparietal craniectomy. The reason is that bifrontal craniectomies, which they did in the Cooper trial, have much worse outcome, but it's more because it's more diffuse injury. And if you can do hemicraniectomies, there's mostly a lateralizing sign, and then these people do a little bit better. So I also have a poll for this study, rescue ICP study. So let me launch this poll. Rescue ICP study. So after discussing this paper, I'm less optimistic or more optimistic or totally confused that a decompressive craniectomy is the right thing for patients with severe TBI. And the other questions I have for the attendees is, if I were caring for patients with intractable ICP after severe TBI, I would perform a hemicraniectomy. I just want to see what the people say here. And it's too bad that our hosts, as soon as you are made co-host, you can't vote, I think. So, so let's give you guys another couple of seconds here. Okay, so let's look at the votes. So luckily we didn't confuse anyone. Thank you for not clicking that. But it is a confusing topic because there's so many nuances to that paper. And I think you're kind of 2/3 versus 1/3. And I think we traumatologists, I think people who do this for a living, I think we still perform hemicraniectomies, not just because that's the only thing we can do, but I think our outcome, the 6 months outcome, is just not long enough to show the difference. And then I think it's interesting also that people here would perform a hemicraniectomy in their patients. And you could see with how many people in a medical treatment group got a hemicraniectomy, it's very hard to stand there and not do something. So that is really reflects real life. So let's go to our next paper. And I added that to the mix. It's not so much about ICP monitoring, but I think it's an up-to-date TBI paper. And that I think I'm going to have a very interesting discussion. And I think Meshvish, are you going to start us off with that?
Yes, hi, it's Mavish. Hold on. I'm sharing the screen. Okay, can everyone see it?
Yep, I can see it.
Okay, all right. So starting off, our paper was effects of tranexamic acid on death, disability, vascular occlusive events, and other morbidities in patients with acute TBI. And I'm Mavish Khan, MS3, and my partner can also introduce himself.
Hey everyone, can you guys hear me? I'm Jeffrey Henson. I'm also an MS3. I'm a med student at the University of Arkansas for Medical Sciences here in Little Rock. So to begin, just to give everyone a synopsis and a background overview, the CRASH-3 trial was a placebo-controlled randomized trial in which the effects of tranexamic acid use were investigated on death and disability in patients who experienced acute traumatic brain injury. So previous evidence from a trial, the CRASH-2 trial, showed that the use of tranexamic acid within 3 hours of TBI injury might reduce death and overall morbidity and mortality from traumatic intracranial bleeding. And also a meta-analysis of 2 previous small randomized trials showed a significant reduction in these 2 primary outcomes with the use of tranexamic acid, yet they had a very small overall sample size of only around 510 patients. So the thought behind conducting the CRASH-3 trial was that it was undertaken to provide a larger data set with a large enough sample size for appropriate statistical power to have proper investigation of these effects. So the primary outcomes regarding this study that were investigated was head injury death in the hospital within 28 days of injury in patients who were either randomly assigned to receive tranexamic acid or placebo within 3 hours of their injury. And the secondary outcomes that were investigated were overall head injury related within 24 hours post-injury, all cause and cause-specific mortality, as well as disability, vascular occlusive events, seizures, other complications, neurosurgery, days in ICUs, and other adverse events within 28 days. Okay, and so just for a little bit of background information, each year worldwide, there are approximately 60 million new cases of TBI, with road traffic crashes and falls being the 2 most common etiologies, and the incidence is increasing. Intracranial bleeding is a very common complication of TBI, and it increases the risk of death and disability. Although bleeding can start from the moment of impact, it often continues for several hours after the injury, and ongoing intracranial bleeding can lead to raised ICP, brain herniation, and death. So tranexamic acid, as a medication to treat intracranial bleeding, acts as an antifibrinolytic agent. What it does is it acts to prevent the activation of plasminogen to plasmin, thereby preventing the degradation of fibrinolytic clots. And it does so and promotes hemostasis. It has been shown previously to decrease surgical bleeding in traumatic external bleeding, and decreases mortality in subsets of these patients. So for researchers for this study hypothesized that maybe the use of tranexamic acid could also decrease intracranial bleeding that was seen in traumatic TBI. So for inclusion and exclusion criteria for this study, adults who experienced TBI and presented within 3 hours were included. They had to have a GCS score of less than 12, as well as any evidence. An inclusion criteria was any evidence of intracranial bleeding shown on head CT, and an exclusion criteria was that if they had any evidence of major extracranial bleeds.
Okay, so for the method portion, right? So this was a double-blinded, randomized, placebo-controlled trial. It was international, so it was conducted in about 29 countries, and the sample size was pretty large with 12,737 patients. Both placebo groups and intervention group were about 6,000 patients, and all were treated within 3 hours of injury. So for the experimental group, they got the 1 gram of tranexamic acid infused over the first 10 minutes and then over IV for 8 hours. And for the placebo group, they just received 0.9% sodium chloride saline instead of the tranexamic acid. And the researchers collected this data for 28 days after receiving treatment or discharge or at death. So patient characteristics. So we can see that both intervention and placebo groups had similar proportions with fairly even age ranges, as well as time to injuries and blood pressures and GCS scores as well. So intention to treat, right? So the effects of the tranexamic acid was analyzed by recording disability, vaso-occlusive events, and other complications at varying times of treatment. So when you had, there were 2 treatment groups where you had less than 3 hours and then greater than 3 hours. And outcomes were also further than subdivided into categories of severity of head injury. So with GCS score 9 to 15, mild to moderate, and 3 to 8, severe. And also looking at pupil reactivity with reactive pupils bilaterally or any unreactive pupil. And then they excluded patients with a GCS of 3 and unreactive pupils when analyzing the data. And for each outcome, they looked at the relative risk and a 95% confidence interval.
Okay, so for the results, so as you can see, I've included the primary results here. A lot of the results for the secondary outcomes did not show any significant differences between our treatment group and the placebo group. Almost all of the relative risks were close to 1 for each secondary outcome, as well as the confidence intervals being inclusive of 1. So for the primary results being that of mortality, between the tranexamic acid and placebo groups, they sub-stratified each group based on GCS scoring, either being mild to moderate being GCS of 9 to 15 or severe being 3 to 8. As you can see for that substratification, the significant results that were found was that treatment with tranexamic acid in the mild to moderate group had significant decrease in mortality with a relative risk of 0.78 and a confidence interval of 0.64 to 0.95. For the severe GCS group, there was no significant differences found, as well as for pupil reactivity. For pupils, where both pupils reacted, they did observe a significant improvement or significant decrease in mortality with a relative risk of 0.87. As you can see, for pupil reactivity in the group where pupils were not reactive, you do not see a significant risk, and the overall, the relative risk between the 2 groups was not significant. I'm sorry, that was for this graph as well. For the figure on the top right, you can see the mild to moderate GCS score and the severe GCS score. The results were analyzed as time to treatment for each group. Time to treatment for the mild to moderate group showed a significant decrease in mortality with earlier intervention. and it increased almost linearly as time to treatment increased. For the severe GCS score, there was no correlation that was found. So irregardless of when treatment intervention was initiated, there was no improvement in outcomes. And the graph here on the bottom is just an overall view of all previous evidence related to outcomes in tranexamic acid use. The CRASH 2 trial showing a significantly reduced mortality with the use associated with tranexamic acid as compared to a placebo, as well as another trial. And new evidence proposed by this trial shows the same. So all of the results over time have been relatively consistent in showing that tranexamic acid is favorable for treating preventing intracranial bleeds associated with acute TBI.
Okay. So conclusion-wise, we saw that tranexamic acid was seen with mild to moderate brain injury to decrease death when given within 3 hours of injury. And then when data was also stratified from time to treat, there was no reduction or increase in disability, vaso-occlusive events, or other complications. So the benefit of tranexamic acid is dependent on two main factors: early treatment, as well as mild to moderate GCS scores. Right, earlier the treatment, the better the outcomes, and no correlation in effects of time to treatment on improved outcomes in patients with GCS greater than or equal to 9. And then we also saw, right, GCS 9 to 15 moderate had the best outcomes seen, with a relative risk of 0.78 and with confidence interval 0.64 to 0.95. And tranexamic acid is most effective in reducing early intracranial bleeding, expansion, preventing devastating neurologic sequelae, and later to treat interventions confer no benefit as extent of damage due to intracranial hemorrhage cannot be overcome just by pharmacological intervention. And also to note that overall the study did have a higher mortality rate, with the intervention group having a mortality rate of 18.5%, and the placebo group had a mortality rate of 19.8%. So overall, we can see that there's no harm in giving the tranexamic acid earlier, right? Because we saw no increase in adverse events, but also not really a decrease. So if you have a moderate GCS and you give it early on within 3 hours, it can be beneficial. And that's it.
Okay, thank you. So let me unpack this a little bit. Can you leave your slideshow up?
Yeah, sure.
I'm going to go back to some of the slides. So go back to the slide where you saw the characteristic of the patients. This is definitely, they set out to show that, and their primary analysis, this slide, perfect. And their primary goal didn't pan out, right? There was no decrease in mortality. They really said our inclusion criteria were that no patient with the GCS needs to be less than 12. What do you see here? Look, at GCS 13, 14, and 15, about a quarter of the patients were enrolled, although they don't fit the inclusion criteria, right? So this is very interesting. How could that even have happened? And luckily, these patients were enrolled, because otherwise they wouldn't have had any significant results. So that really makes me very suspicious about the validity of the results to see something like that happen. Go down now where you had the forest plots about the results, please. So also, if you look at the supplements, perfect, thank you. Also, if you look at the supplements of the study, there was a very big discrepancy of where the patients were enrolled. Most actually, I think 2/3 of these patients in this clinical study were enrolled in Bangladesh. So it is a very big, a very imbalanced enrollment from different centers, and definitely biased to second to third world countries compared to first world countries. I am a clinician, and I think I have an advantage to have been treating mild and moderate TBI patients for years. And if you would ask me what my mortality is of a mild traumatic brain injury patient, I would say it's less than 1%. I mean, I don't even remember in 10 years of having a mild traumatic brain injury patient die. Even a moderate traumatic brain injury patient, very rarely do these patients die. Severe traumatic brain injury patients, different. I think our mortality is similar to mortality we see in this study. And that really raises some questions for me about their treatment, misclassifying patients, and how maybe these were not really mild traumatic brain injury patients. Or were they mistreated, misclassified, or what is the treatment protocol that they actually have such a high mortality in patients, which we don't see here in the US. You guys also mentioned about the idea for giving tranexamic acid is to stop the bleeding. And we again have to very differentiate between bleeding in a severe traumatic brain injury patient versus bleeding in a mild to moderate brain injury patient. The bleeding we see in mild traumatic brain injury patient, that could be a 1 centimeter contusion, for example. So walk through that case with me. So we have a patient, GCS 15, has a 1 centimeter contusion. He has a 20% chance that this contusion could double in size. We call it blossoming of contusion. So in a paper, you could read he had a 100% increase of his hemorrhage, right? Double the size. But going from a 1 to a 2 centimeter contusion, the patient is probably clinically completely asymptomatic. He wouldn't die from that increase. So I just want you to understand that stopping that bleeding, making 2 millimeter to a 4 millimeter subarachnoid hemorrhage, not gonna make a patient live or die. There may be some cognitive effects, but this wasn't evaluated here. In patients with a poor GCS, with a big contusion, I think 100% change could make a big difference. So very much differentiate. So I'm very skeptical about the decreased mortality in mild to moderate TBI patients with the tranexamic acid, because I cannot understand how it would decrease the mortality. I don't understand it, how that would happen, because again, those bleeds are mostly very small, and they wouldn't make somebody go from walkie-talkie to being dead. But it could be different paradigm, different treatment regimens that we have in the studies that contribute to states that contribute to the study. What else did I want to say? I think what my personal take home is from this paper is it's safe. Okay, giving tranexamic acid is safe. The way we evaluated this paper when it came out for our institution, we don't give it to our mild TBI patients, but we reserve it for our moderate TBI patients, people that have a lot of contusions, that kind of teetering between a moderate to severe, and we reserve it for that patient. So I just wanted to guys give you guys a little bit kind of background from a clinical standpoint. And I have a poll here for you. So let me pull up this poll here. Okay, so can I relaunch the poll? Poll is closed. Okay, good, relaunch it. So what is your experience with mortality in complicated mild TBI patients? So this is the mild TBI patients, and it is extremely low. Just I want to see what kind of your experience is. And then I kind of want to see from the group, if you're going to give TXA to your mild TBI patients or go against it. I think you guys are all, okay. I need a last good push here for more than 2 people to vote, and then I'm gonna share the results, and then we can wrap it up. Okay, we have 23 people that can vote, 10 votes in. Okay, 5 more seconds. Okay. So let me share the results with you. So yes, I think question 1, I think you guys agree with me that the mortality rate of complicated mild TBI is very, very low. I don't think I convinced you not to give TXA, but we are not giving it for our complicated for multi-BI patients, but we were reserving it for the complicated one. Well, I want to thank everyone that was part for the panelists. I think you did a fabulous job of distilling this paper down and presenting it in 10 minutes. This is not easy. Everybody can talk for 30 minutes, but it's hard just to talk for 10 minutes. So I want to thank my co-hosts and everybody that listens, and I will conclude. So thank everyone.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.